president of PLATO. It is my pleasure and honor to welcome you to this first colloquium of the PLATO year 2020-2021. This colloquium is known as the Arthur Milhaupt Colloquium in honor of Arthur Milhaupt, who was the founder and one of the originators and first president of PLATO. This is being presented in a webinar format. It's being recorded for our members and guests. It will also be available to the general public on the PLATO YouTube channel and also on the PLATO public website by means of a link that you can have access to. I want to mention that our speaker, Jeffery Wilkins, donated his, voluntarily, wasn't forced to do this, he donated his honorarium to PLATO. And that is a good starting point and a reminder for the annual giving campaign that will be coming up. So I want to publicly thank him for doing that and remind everybody to consider and pay attention to our forthcoming annual giving campaign. Lastly, our member survey is outstanding now. It will be outstanding until Thursday at 6 o'clock. It really has to do with shaping the future of PLATO, and we hope that all of you who receive it will respond. It is a very important part of our making a post-pandemic plan for PLATO. With that, I would now like to introduce Hank Zangwill, who is the chairperson of our colloquium committee, and he will introduce our speaker today, Dr. Jeffery Wilkins, who will speak about the opioid pandemic. I'm sorry.
Basic research studies with UCLA and medical centers across the United States. Dr. Wilkins also has a strong record of community service. He's currently the director of the Brent Shapiro Foundation and served previously as board member of the Matrix Foundation, the Lincy Foundation, and Cedars-Sinai Psychological Trauma Center. It is my pleasure to introduce Dr. Wilkins.
Yeah, I just need to be able to see. Do I need to share the screen? Okay, we're good. Okay, so today we will discuss, I'm going to move this out of the way. Okay, three main areas. The diagnostic criteria of substance use disorders, including opioid use disorder, the neurobiological basis of substance-based addiction, and the treatment and prevention of opioid overdose and opioid use disorder. It won't necessarily come in this exact list manner, but we'll go from here. We're going to start, before I talk about this very first slide, I want to point out to you that in 2018, 185 citizens, individuals from the US died every day, 185 died every day in average with overdose, substance overdose, of which 2/3 were all caused by opioids. What that accumulated into, what you see now in front of you, is over 70,000 deaths in this space in 1999 to 2017. This is also showing by gender, where males are 2/3 of the overdose deaths. This is an important slide in that it begins to give you a sense of the various substances and their the death rate from them. For example, the top, as you can see on the top right of the figure, is talking about synthetic narcotics. Well, that's come to mean fentanyl, which is 50 to 100 times more potent than heroin, and it's the greatest causer of death with these overdoses. Before fentanyl showed up, and I'll talk a little bit about that later, there were overdose deaths and they were significant, but they weren't like these sort of numbers, where in fact the overdose death rate in the US now exceeds automobile deaths. Notice as we go down that list though, You have methadone, fentanyl is listed here, and that those all supersede prescription opioids. But then you have heroin. There's a lot of deaths related to cocaine and benzodiazepines and psychostimulants as well. The males continue to increase, but this is, yeah, okay, so that's, okay, sorry, I'm gonna go, let me go back, sorry. Okay, this shows the male predominance as already stated. I'm getting to where I can do this manually. Okay, this is versus or the whole issue with prescription opioids. Prescription opioids were really the monster contributor to the beginning of the opioid epidemic in the U.S. It was basically from a particular company that came out with a synthetic opioid that was very, very popular and turned out to be, the US was pretty much the only user of this opioid, and it had a major play in the way it was marketed. It was marketed to GPs and other physicians across the country as a drug that was safe, that would be very effective against pain. In fact, it is very effective against pain, but it is far from neutral, and started the death rates that started to increase around the turn of 2000. This is showing you the numbers with heroin, and heroin is increasing, but it's increasing with fentanyl. And wherever you see the wordage synthetic narcotics, you're really talking about fentanyl, this incredibly powerful substance, which is increasing here in the death rates. And notice heroin all by itself is actually diminishing in a significant. So it's actually the fentanyl containing heroin, which is now the de rigueur. It's the most common combination of substances causing heroin-related death. This is showing you that cocaine has also been now linked with fentanyl, and so this is why there's these upticks in cocaine deaths with any opioid, and certainly synthetic opioid, which is this top one. Benzodiazepines, similar, but all by themselves can be lethal, but in the combination of fentanyl, again, it's very high mortality. It's always been dangerous for sedative hypnotics, of which benzodiazepine is one, and but now with the addition of fentanyl, it further increases the problems. So a little more about fentanyl. Okay, it's a class of what they call full agonists, meaning it's 100% active at the mu opioid receptor. It was developed by Janssen in 1963. Interestingly, it sat there for many years and then kicked in right around 2000 in a very high level. It has a variety of analogs. This one, carfentanil, actually is more potent than fentanyl by 2.5 times. So you can imagine how dangerous that is. Well, where did all this come from? This lag of 40 years after Janssen produced the fentanyl line. It's been taken up into Southeast Asia, particularly what they call the Golden Triangle, Laos and Thailand. And this sale of this is happening all around the world, and still predominantly from Southeast Asia and East Asia. This shows you the increase of the fentanyl line and how it dramatically increased from 2013 through 2017. right. That wasn't deaths, this was just appearance and measurement. Here's a quick listing of fentanyl at the top, not surprisingly, above heroin itself and above prescription opioids. But fentanyl by itself or with heroin or prescription opioids will remain continually at the very top. Well, what about opioids and opiates? First of all, I'm going to go to the bottom, and you'll notice that the term opioid is used to define all chemical compounds that act at opioid receptors. And what that really tends to mean is what's called the mu opioid receptor. Opiates are the two substances that can actually be derived from the opium plant, namely morphine or codeine. And this is certainly very interesting. In very old historical records, the opium poppy is discussed as far back as 3400 BC. It has been with us 5,500 years. Okay, so what about the mu opioid receptor? I'm going to discuss one aspect about this. So why do people have these opioid overdoses, particularly when fentanyl is in the room? Why is that? And why they also can die, of course, from heroin. And you'll recall that the fentanyl and heroin is much more lethal than heroin by itself. Well, what powerful opioids can do, and fentanyl is much more powerful than heroin by 50 to 100 times, it acts in a different way at the mu opioid receptor. It acts at it, but then it calls for this arrestin, which is a molecular component that itself, when activated through the mu opioid receptor, let's say of a prescription pill, prescription pain pill, it could, and I'm sure it does, diminish respiratory drive if one took 2 or 3 or 4, but it wouldn't kill you. But with more powerful drugs like fentanyl, in a variety of ways that can be taken, including smoked and injected and so forth, it calls into action this arrestin molecule, which itself is solely directed at that point towards controlling the respiratory system, and it shuts it down. And so there's a lot of interest is, okay, why not differentiate between the extraordinary molecular effects of an opioid and the respiratory suppression effects? Because the respiratory suppression effect is clearly not of any benefit in any way with the actions of opioids. And of course, opioids are used to impact pediatric treatments at times, and certainly pain. It's the #1 in the world most effective substance there is with severe pain. There is no better molecule. There's a reason all this effort has gone into various chemical companies to make as many different opioids as they can market. This is pointing out that, and the very last bullet you'll see, despite 30 years of basic neurobiological research, that there is yet to be an opioid that is uncoupled from respiratory depression. On the other hand, amongst other entities, Cambridge Medical Research Council in the UK has been on an effort to take all of the our FDA approved drugs and determine a way that there might be unique ways to look at the variants of them. Variants, when I say variants, I mean variants of their metabolism. For example, they've been able to measure, and I'll show you at some point, here we go, that the so-called wild type response to the left of this complex molecular structure, which is the mu receptor, would normally be right here in the middle, the normal response of any of the drugs. And we're talking literally 100 drugs that are common to any of the, you can imagine, from antidepressants to drugs that affect the gastrointestinal system to cardiovascular, etc. But if you track gene activity, including across people, there's a nice symbol for the human species, then you can actually find some variants in people that have an increased response. You know, this is the whole point about people respond differently to medications, because people do have different response powers or strengths that don't fit the normal response, and similarly can have reduced response. So one of the things that the Cambridge laboratory in the UK is doing is looking out for a reduced arrestin coupled response in what's called the G protein complex, to then see if they can clone this phenomena and see if they can in fact produce ways of changing how this all acts in people by literally giving a medication that will create this, the effect, if you will, of a genetic variant. It wouldn't have them have a genetic variant, whoops. It would, it would in fact just act in a different way than the normal opioids do now, because it would be, it's taking advantage of looking at the new complex that comes from someone with a genetic variant. We're going to get into treatment fairly soon, and I'm going to start with the basic understanding of the neurobiology of addiction, which has been extraordinarily advancing in the last few decades. Much of it based on animal work, but now lots and lots of work with human test subjects in a variety of ways. So this begs the question of, okay, how does one get addicted? Well, one gets addicted by 3 neurobehavioral mechanisms, which we'll talk about in a second, and are illustrated here by this diagram. The traditional way, and I do work with young people on this, is through the so-called binge intoxication stage, which is the aspect is that they're introduced to a drug of some kind. Their brain likes the drug response. They like the drug response. And now, depending upon the frequency of the use and the amount of the substance, they may or may not enter into an addiction creating process this way. If they are, I've done work with young people in cannabis, and as you can well imagine, some people using cannabis would use it just rarely, and some people would use it frequently. And it's the individuals who use it frequently, namely pretty much every day of the week, or even every weekend, that have a much higher likelihood of developing an addiction process with cannabis in this. Then there are 2 other models, the so-called negative affect withdrawal. The process of withdrawal is if you You don't get into a situation withdrawal if you're an episodic user. You also, though, don't want to gamble on that you can live that life. It's not always easy. You're pretty lucky if you're able to do that, because a lot of people think they will do that, and then they try and they don't, and they become a steady user, an increasing amount user, and it starts down this path. Because once you get into the concept of withdrawal, that is really a signal and a marker, rather, for a variety of biochemical events that creates negative affect. Negative affect meaning feelings of you're uncomfortable, you don't feel right. You may have withdrawal signs where it's difficult to sleep. You feel anxious all the time, sweating, and so forth and so on. But there's an interesting twist to this, and I think I have a slide of that coming up. There was Richard Solomon at University of Pennsylvania in the early 1970s. In 1973, he wrote about a concept of opponent process. What he meant by that is all this derived from a historical basis of psychology, but he noted that it appeared that all liked drugs that were liked, and opioids are very much liked in their response by most people, not all. As it creates the positive reaction in the brain creates something that certainly was not an intuitive thing for me to think this way, but it creates an opponent process of a negative, an equal weight to the positive. And it starts at the beginning, and if you don't move on to frequent use, you wouldn't really have this negative affect ring of peace. But if you continue to use it, you will. And unfortunately, oops, I keep hitting the wrong thing there, sorry. It lasts longer than the positive experience overall. And over time, let's say you became a regular user of opioids, over time, which interestingly happens, is it isn't so much the drive, because see here, the drive is the positive. They want the positive reinforcement. But once it gets past a certain point and now engages this set of anatomical difference, this is what's called the extended amygdala area, it actually no longer even needs this, because this doesn't work anymore. The incentive that was derived by somebody saying, hey, I've got some opioid pills, would you like some? Or even worse, they would just say, hey, let's get together. And that would have been taken over by let's go get opioids. So the let's get together, which might have been a non-drug event, has become a drug event. And in this piece, the interesting thing is many of you may know the difference between positive reinforcement and negative reinforcement. Positive reinforcement is all about this 1/3 of this triangle, if you will. This is negative reinforcement. So here they're using the drug not for its positive effects. And this guy, by the way, goes on for a lot of substances, including alcohol, but you use it to turn off the agony of the affect. So here it started with, you liked it, so to speak, the person liked it. Again, if they find a way to just use it once in a while, probably won't go on to this part. But once it goes on to this part, you now have a brain that's truly changed. It's not going back here. It's going to keep activating here. So now the push in that individual to use the drug way dominates over any of this memory. And instead now is just trying to end the horrid. But once it gets this far, it tends to always move right on to this, which is an anticipation, preoccupation process in yet another part of the brain. So we have three very distinct brain areas, all of which are saying to the user, you must use. Here you must use because anything ever related in your thinking to your start of use and certainly to your increase of use, maybe it's seeing a certain person, maybe it's going to a certain place or certain house, this will trigger this. So all kinds of things are going to drive cues here. Like your cousin comes over who you don't see very often, but used to bring opioids over. So you have that going on, you have the terrible way you feel, and you have this forced anticipation, preoccupation of the importance of getting the drug, both to appease this and to some level appease that. But now you have three, I call them wheels turning. You have this one turning, you have this one turning, and this one turning. And quite frankly, that is very, very difficult to stop. And with opioids, much more so because of the issues I've already mentioned. And it is, again, well liked by lots of people. It starts to be, instead of their pain med, it starts to be their emotional soothing med. And that can all work for a little while here, but without great caution, it can move to here and there, as I've been pointing out. Well, the diagnostic criteria fit these three areas. This is just an introduction that, for example, with the DSM-5, which is the world we live in now, the Diagnostic Statistical Manual from the American Psychiatric Association. This has been the new one as of 2013. The DSM-4 was around for a couple of 3 decades before that. So the DSM-5 has 10 variables, which include hazardous use, which, by the way, ends up being like the second or third most pronounced. The biggest one, oh boy, sorry. The largest one is increased use. Okay, so we drop down to here, withdrawal and tolerance. Withdrawal, we've talked about. Tolerance is when you need more and more of the substance. That doesn't really start to happen until you get close to that red zone, that item 2 of the 3. Use larger amounts tends to be the number 1 causal stuff of this diagnostic group. Number 2 is hazardous. Psychological problems is number 3, and we go from there. But all of these, towards the end, so to speak, if I can go, I'm going to come back to this in a minute. What I'm talking about here is the spread of these behaviors over a 3-year period. All the people here were studied for 3 years in depth, and each one of these buttons is markers is a number of people. And here is your using larger amounts, as I mentioned, and there's the hazardous, as I mentioned, and so forth. But in the end, when you are fully addicted, they coalesce up here. So you have much better chance here. You're getting into some real trouble here, and here you're in the top of that trouble and have a lot of other things to fight it with. Now, if we call number 1 the binge intoxication, number 2 the negative affect, and number 3 the preoccupation anticipation, I just want to point out that most of them are all impacted by you get into this cycle all through the binge intoxication. But you don't need to do that exactly. For example, if you have a disorder that turns out to be most likely depression or a depression variant, and we know that people who are depressed have a higher use of of opioids and other substances, you can actually enter here. You don't even need this introduction piece. You can, like for example, you might be getting some pain relief from surgery or something, and you might notice that the symptoms for your depression go away. I'm not saying all depression, and I'm not saying all people, but it's definitely, the data is real and of significant numbers. And here, it's more if you have an anxiety-like disorder. It's a little looser than here. It's pretty nicely linked, but an anxiety disorder can predispose to this category, and you could come in through here. But I think most come in through these two. Here's the second most, I would say. But once you are using routinely and heavily, or even moderately, but continually, you already probably got yourself all three. I've already discussed about this. The basal ganglia, let me just differentiate the areas. The basal ganglia is a unique group of nuclei that are linked to drives. So this is all about the drive to get the positive aspect of the drug. You had a taste, you liked it, you wanted to get back to it. So that's this part. The extended amygdala, and I spend a lot more time talking about that, drives withdrawal, all of which is negative in its forms. But the negative affect stage is the one that's similar, actually in many ways, to depressive disorder. And the prefrontal cortex, which is our logic and judgment center, it derives this preoccupation and anticipation because it's interested in the same thing. So it actually loses. This is where the brain does another negative thing. It actually convinces the brain that it doesn't need to have things that are fun for it. It doesn't need exercise. It doesn't need to play music anymore. And eventually it doesn't need to go to work or take care of the kids in extreme situations. So I'm going to point out, when working with young people, there's a very unique thing here. This portion that drives this in the brain in adolescence is hugely intact, comes in roaringly strong from 12, 13. This doesn't come in until about 17, and in some a little later. So you have these adolescents, which is a huge part of why adolescents have issues with dangerous things, because they don't have these judgment centers. These are not even wired yet. They start their wiring in most adolescents, females earlier, but they start around the 17 and don't complete in many males until around 25. Females would be faster in both, start a little earlier and end a little earlier. So you have an out of control here with adolescents without any check and balance structure here. This is just describing this. I'll just point out little aspects. I want to keep moving. This corticotropin releasing factor is used actually and has been as a measure of depression. And sometimes back in research about the antidepressants and how they might respond in mammals and humans. This was done. And of course, this is the creator of the negative affect, which goes along with stress hormones, of which corticotropin is part. The whole corticotropin or corticoid activity is the shared aspect between affect or depression and this stage of addiction, the negative. So I'm going to move on. I'm not going to repeat things I've already said. Incentive salience is where you increase the drive towards the drug, and it downregulates. As it increases the drive to use the drug, it's downregulating at the same time. If you're a young person, your schoolwork, your interest in sitting with family dinner, all these kind of behaviors go the wrong direction, and they're replaced by this. And then there's that opponent process I described to you by Dr. Solomon, which just frankly he figured out with some others, and at that time. So it's been around 50 years, the understanding of this, but it really didn't get applied to the neurobehavioral work until more recently. Okay, that was about Dr. Solomon. I already said all of that. This gets into the fact that there are different neurotransmitter systems in our brains, and these impact on the functions of the prefrontal cortex. It is the neurotransmitter dysregulation that can take an adult prefrontal cortex and turn it dysfunctional. It's not functional in the adolescence, until 17, male, more male and female, but more male. But the way it's taken away in adults is through these alterations in these basic chemicals, all of which are being impacted by the three rings or wings and wheels that I talked about. This is talking about the drug cues, which I mentioned earlier, that these cues have replaced the other cues. So this is the negative cues replacing the positive cues. I'm going to keep moving. Treatment. So when fentanyl came into picture, and it's linked with high numbers of deaths, this is a quote from a user. So now they're cutting the heroin with fentanyl to make it stronger. The heroin is so strong that you get the whole dose of fentanyl at once, rather than being time released like a patch of fentanyl. Fentanyl, of course, was being used for pain reduction with patches. And that's why people are dying, plain and simple. They don't realize they cannot handle it. And then this next slide gets to the specific aspects of that. That unlike somebody using opioids, and they just fall to the floor during their conversation with you, in the middle of a conversation, well, the difference between them and somebody that has fentanyl in the drug they're taking is these people fall away as they're completing the injection, if they're doing intravenous. And by the way, there's a very unfortunate pathway to people who have never used intravenous drugs when their prescription opioids were too difficult to get and too expensive, because they did get very expensive. The cartels, the drug cartels, knew to overfloat other substances, particularly heroin, and then eventually heroin and fentanyl. And so they started to replace it with heroin, and then, unbeknownst to many of them, fentanyl eventually. And then even now, unfortunately, even though they know of fentanyl, they're trying to stop their negative affect and withdrawal and all of that, so they tend to still keep using. But the point is here, unlike the person who's talking falls to the ground, but he was talking to you, they can't even, they're not even conscious once they get half, 2/3 of the drug into their vein. And it's not like the venous transfer into the brain is that fast. but this drug is so powerful, so much more powerful. Okay, so let's look at opioids for a quick moment. There's the agonists, and fentanyl is a full agonist, as is heroin and morphine. You make heroin from morphine. Oxycodone, OxyContin, if you will, was that drug I was talking about that was manufactured by the company that introduced, if you will, the opioid epidemic, and it was eventually linked to heroin use and so forth and so on. Partial agonists. Now, this is the molecular treatment. We're going to be talking about in a moment non-molecular treatment, but this is the molecular treatment. And quite frankly, if somebody is trapped by any of the opioids, in particular heroin, because it's generally intravenously used, and fentanyl, then people die so quickly. But even prescription opioids, buprenorphine can be very, very helpful. It is not a cure, but I'll show you why in a second, why it's so critical to use this, regardless of the, and in addition to, if people want to use non-medication treatments, and there's nothing wrong with that, of course. So now, yeah. So the partial agonist, the real thing here is to get you to buprenorphine. Now, Trexon, which is a full antagonist, is being used in depot forms, shot-like forms, and one is naloxone. You've probably heard about naloxone. It is supposed to be prescribed to all patients that medical practitioners, if they know that somebody's got an opioid problem, they're supposed to be giving them lots of options of how to take naloxone. They don't do that as much as they should. The numbers are down, though they're increasing slowly. But and the use of this drug is actually turned out in some instances to be definitely equally as active as buprenorphine, though it's not an agonist. It's actually an antagonist. There is buprenorphine with its various construction elements, and there's morphine, which is what it's replacing. You know, it comes in and moves this one off of the mu opioid receptor. I want to take a divergent step for a moment. I mentioned non-medication treatments. Trying to get the time here. One of the non-medication treatments would certainly be any of the 12-step process of treatments, and there's many, many variants. It was founded in 1935 by Bill W., a patient at that time, and Dr. Bob, a friend of his. Bill W. was working with an Episcopal clergyman from the worship and spiritual side, and Dr. Bob, in communication with his medical friends, had learned that doctors were beginning to talk about which is really obvious to us now, that alcoholism is actually a disease. Those two, of course, Bill W. and Dr. Bob, introduced pretty funny, Alcoholics Anonymous in 1935. Recently, now I'm having you read, if you wish, the 12 steps. You may not know the 12 steps are easy to get at any point through any search engine. But this is an interesting 2020 article that came out through the Cochrane database, a well-known academic structure that shows the absolutely demonstrated positive benefits of 12-step process. 12-step process now works with approximately 10+% of people with any particular substance. and some much less. Frankly, the opioids would be much less because it is such a, well, dangerous, and it changes one's life so dramatically and powerfully. But it can happen, and in the positive, and so just reminding you of this approach. There's also a lot of psychological treatments, cognitive behavioral therapy, probably almost all of you have heard about. That's good for helping people with depression and somewhat anxiety disorders and a variety of other behavioral disorders. And mindfulness, you may know of mindfulness, and also motivational enhancement, you may know of that. So these are all very useful, and I think, but with someone with a clear use disorder of opioids, to me, and I think mostly to the field, it's get them on buprenorphine. They can also go on methadone, but get them on buprenorphine. This also works with pregnancy. We were working recently with a young woman who's, but the point is, we've worked hard to get her on the buprenorphine because the baby's born much more healthy, born at the right gestation time rather than, way early. The baby needs much less medical care, is out of the hospital sometimes in 2 days as opposed to 10, and so forth and so on. I think while I still have this slide up, I want to say the real thing is to get help. And with the program, Dr. Mr. Zamet and Mr. Zangwell, we're going to be putting together some resource document for all of you that will hopefully go up at the time that this goes up as a video. This is why buprenorphine. This is 2000. Well, gosh, it's whoops, it's marked off. This was early 2000, 2003 or less. This is pretty striking, isn't it? This is treatment retention, and it's above 80%, 85% or so, are maintained by then would have maybe, I think, was even a smaller dose than is used sometimes now. But if they were given placebo, 25% died within a very short period of days. This is a 1 full year. People followed for 1 full year. And to have anybody in any opioid program hanging in there that long is pretty darn good, frankly. So this is when buprenorphine startled the world, and including this next graphic, which shows a non-opioid treatment for withdrawal. It's effective, not nearly as effective as an opioid-based withdrawal. And buprenorphine is that. And you can see that this was a very much more short time, but that they were retained much higher than the other medication was able to. So this was a 2005 study by Walter Ling from our own UCLA system. These are the signs of opioid withdrawal. They'll be, you can refer back to these. This is the one that, somebody who's really trapped is going to be having all the time. This gets a little bit to that opponent process that was talked about, where what we'll say positive affect is replaced by negative affect, and positive incentive driven at that first wheel of the neurobehavioral process is replaced by the second wheel, the negative reinforcement where you're just trying to get away from terrible feelings as opposed to desiring a positive experience. And this is us. So we're going to be getting you resources from the Substance Abuse Mental Health Services Administration. I will also be trying to put together a listing of, and I have to do this in a way that's non-favoritism, that just basically gives you access to academic centers, non-academic centers that treat. I'm probably not going to do promotion of private for private programs, but we'll certainly give anything that relates to the public or that has appropriate ratings. This gives you a nice look at how the opioid poppy is cut and the material collected from which you can ultimately derive morphine and codeine. Thank you very, very much.
Thank you very, very much, Dr. Wilkins. We really enjoy your presentation. We have a number of questions from our members. Let me ask you some of them. So I try to get in as many as we can before we finish. One of our members asked that if Obamacare is overturned, what, if anything, will be the adverse effects on the opioid addiction and deaths? And our member asked whether you could answer this in overall terms and in specific ones such as demographically and regionally.
Okay, a very impressive question and a very important one. I think a lot of us are tracking the process, this legal process about the potential loss of well, say more change to ACA, the Affordable Care Act and Obamacare per se. I think politically, I'll leave that to the audience. You could probably think through, okay, I'm president, and let's say I want to do away with Obamacare. Do I do anything that makes the opioid epidemic worse? That would be a question I'll leave with the audience. I will say it a different way. I will say that we need in this country substance abuse to be something that's not necessarily exclusively, and certainly not with the non-medical approach. That's fine, certainly. But in the approaches that are solely for money, and a lot of people can't afford that kind of money for the very fancy, Malibu-like places and so forth. Nothing against that. I'm not taking a shot at them. I'm just saying, from a public health perspective, the goal is to have GPs and virtually most areas of medicine to have some sophistication about substances, because the numbers are so high in their patients. Somebody may be coming in for a rheumatologic problem, or some very unrelated to addiction issue. And if the physician doesn't see them as having a substance potential problem, and it's not hard to see often, and of course the main thing is you ask. That's what we need the physicians to do, the physician's assistants to do, the nurse practitioners to do. You get what I'm saying? All of these professionals working to figure this out. Because if you do, and you get them in ideally some form of treatment, which, by the way, the US has not done so well for a long time. Even recent studies show that only about just under 25% of anybody that really needs treatment is getting it. That's most unfortunate. But on the other hand, it's a lot better than it was. It used to be down at well under 10%. So this is better. We're moving. And I think, like, part of the reason for this presentation today, and hopefully a lot more communication through media and so forth about substance, The point is to get rid of the stigma around it, which removes the social process, removes people from caring. Remember, there used to be all kinds of, and still are, stigma about mental health. Depression has changed a little in recent years, but the rest of it hasn't changed so much. But even depression can still have stigma to it, and a whole variety of neurological disorders, and certainly all of the substance disorders. I think we have to get smarter we're a very diverse group of people in this world, and certainly in this country, and we have to find ways that we just get smarter about everything. And one of the things we need to get smarter about is healthcare, what you need it for, how you can prevent things. And prevention can happen a lot. There's a lot of literature out there, and we'll be trying to get you some resources on this for young people. And may I point out and remind that most people who are addicted as adults, high percentage started as young people. They started in their adolescence, child and adolescent. I've worked with people who are 8 who have substance issues. I think that's...
Okay, well, let me ask you another question that we've gotten in. Is marijuana a stepping stone to other drugs? And do you agree with penalizing marijuana use? And if so, why?
Well, I'm going to have my own inherent biases, having just finished with a writing committee of the American Society of Addiction Medicine on their latest policy about cannabis, and having done the same 5 years ago. Long story short, remember I was talking about I wasn't trying to give a go-ahead sign to the people who can actually only once in a while use a substance. I was just pointing out the realities with the brain. But if somebody used, and actually in Canada, which is the whole country is now approved marijuana use. They say, here's what you have to do about everything, and certainly cannabis. Don't use it every weekend. If you're going to use it, they already knowing that the young people are using. Don't use every weekend. Certainly don't ever use it every day. Because once you get to the every day, and even to some extent the every weekend, you've already changed the brain if you've done that for any reasonable period of time. It doesn't take long. And that will be a problem in a lot of ways, as more and more data is beginning to show that if you do a lot and frequently, it's not saying that even little bits aren't a good thing. I'm just trying to point out the obvious, that the big problems that happen tend to be with the big use. And not the monstrous use, just some big use, like every weekend. It can change the brain and things cannot go well. There's all this interest in medical use of marijuana. There's probably some valid points in that. And we know there are some, because actually the FDA has approved some work from the cannabidiol for treatment of some kinds, admittedly limited populations of people with particular kinds of epilepsy and so forth. But the point is, it would be surprising if there weren't components of the cannabis plant that have some beneficial treatment in the outcome after a lot of research. But
are the effects you're addressing true also of the various salves and ointments and brownies and other things that you would take either orally or administer topically?
Well, see, the problem with how everything is sped up is it's like with drug development, you have FDA, you have required FDA approvals, which is to prevent problems that aren't understood at the time. There's none of that going on really with the cannabis and cannabinoids. I mean, cannabidiol, which you may have heard about, that has no intoxicant effects, but it also doesn't mean that it's a treatment for everything, because it will, like everything in life, have some potential toxicity in someone. You know what I mean? So we just need, again, to be wise and smart. I would not say all these other things are great. The most dangerous probably appears to be the inhalant aspects, the vaping and all of that, because that can put such strong, powerful solvent-based chemicals in your lungs. If you can imagine this, we know nicotine addiction is still an issue. Young people are smoking nicotine that minimally is 2 to 3 times the strength of the strongest cigarette as they smoke.
Okay. How does opioid addiction compare with meth addiction? Do addicted people tend to use both?
Great question, very knowledgeable question, because certainly, let's say 3, 4 decades ago, and then decades and decades before that, clearly all the amphetamines, and certainly methamphetamine, have shown to be a strong relationship with the use of opioids from both sides. Meth addicts seeking out opioids and people on opioids seeking out methamphetamine, both seeking the increased power of the drug effect. And it really is. This goes back to literally 100 years ago, the use of smoking opioids and taking crude or amphetamines at the time. So people that use substances, of course, easily get it, that if you add like a speed like amphetamine product in with an opioid, it really heightens the opioid experience. So people will do what people do.
Is there a geographic aspect to opioid deaths in the United States? And if so, why?
The East Coast and North and sort of the upper South, like Virginia, have huge problems. Indiana has a huge problem. But the Northeast has some huge problems. So we have our own problems in California, but those other states have worse issues and have had all along with this. And in fact, the pill mills were in this country were mostly driven either externally from coming from like through Mexico, but being Southeast Asia, all these various places coming over from Afghanistan predominantly and so forth. But the East Coast had the predominance of those mills. Yes, so that's a very good question.
Okay, I know, and there are a number of people who are in chronic pain, whose physicians have been very reluctant to prescribe even relatively mild opioids to relieve. Has there been an overreaction among the medical community to the use of opioids as a pain reliever?
Very thoughtful question. I would say probably, because frankly, there is some draconian piece of any kind of regulatory process. I think we might all think of things in our lives where that's come true. I think, but I think on the other side, what's been very positive is the recognition and the research behind it, that there's a lot of, if we're going to stick with medications at the moment, and also non-medication approaches. But from the medication side, the gabapentin, other medications can actually diminish the pain and even be combined with weaker opioids to be very effective even for severe pain. You want a doctor that is comfortable with the challenge of treating you, but willing to give you the opioids if you really need it. You can't, it's not fair to not, because severe pain is a terrible, horrible experience. And yeah, so you get with the right doctor, I think you're in good shape in this one, but challenge them, ask them. And the doctors that clearly are running away from you, if they can give you something that is as effective, great. But if they can't, go find a doctor that's comfortable with the challenge.
Are you recommending somebody like a pain specialist?
There are some amazing people who are not pain specialists at treating pain. I must say that. some wonderful doctors. There's always been wonderful doctors, and sometimes the other side. But yes, there are pain specialists, but you have to keep a little bit of an eye on them because some of them might be a little so anti-opioid because they would be under a little bit of a microscope by control systems, right? So it's not easy. Look, we all know it's not always easy to get a great doctor. When you get one, never let go.
When you send out your materials to our members, if you can include a list of the good doctors, we would all be very grateful.
I will, and then I'll have to burn it because I want to be safe.
Dr. Wilkins, what is your view on community use of Narcan to respond to an opioid overdose?
Oh, gosh. If one has a friend, a relative, and lots of us have relatives who are using opioids in unsafe ways, we should have Narcan, if you will, or any of the other naloxone products in nearby to help that person. And you have to remember, in this day and age, you can't do the original give a dose and then follow it up as needed. You have to start with 2 doses and then just keep going because the fentanyl is very difficult to stop.
Okay. One of our members asked that, medical use of with respect to medical use of opioids, many people are fearful of using opioids for pain because they're fearful of addiction. So they take no pain medication at all. Is this a realistic fear? What should they know?
I'll just give you an example. I talked to somebody not that long ago, smart person, did not want to do opioids for the reasons you say. But I talked to the person about not that whole neurobehavioral 3, rapidly spinning aspects, but when you have pain, actually, this has been known for a long time. If you have severe pain, let's say you had surgery. If you have severe pain, there is no better treatment than an opioid. But you should be literally counting the days that you take it. You see what I'm saying?
Yes.
You'd be really smart about it. Hopefully by now your doctor won't prescribe a huge excess, which sits in a drawer and calls you through the ether. I'm here. Remember how great you felt when you first used me? I mean, really, it does. You don't want that. But if you count the days and ask yourself, do I need it? You'll know if you need it, because if you're in severe pain, you need it. Take it.
Okay. What actions would you suggest that public health officials take to reduce or manage the opioid situation?
And was that physicians, or what group? What were you saying?
I said, what actions would you take?
Systematic changes, you mean?
Yes.
Well, I've seen this pendulum swing because I'm old enough between, opioids, too dangerous, you can't use them, to, like with the OxyContin story, have as many as you want. Here's an extra 30. Those swings are always dangerous and not useful, and show, like so many aspects in life, that pendular swings are not, the smartest way to go. Rational thought is the way to go. And I think, actually, and I would hope to support some programmatic things in this direction, that like we need more things through the media, which are interesting programs discussing with experts about what are some of the, being careful not to say the wrong things on media, which could get you sued, but talking about rational medicine for everything. You know what I mean? Keeping up. I think everybody, like your audience, the PLATO audience, brilliant audience, they should all have a fairly good understanding of addiction, which hopefully this helps some, but certainly any medical issues they have. It doesn't mean you're going to go to medical school, but you know how you can get pretty much immediate access for so many articles now. And you don't need to read them all either. And you can talk to friends who you know a lot more maybe than you, but you shouldn't be ignorant. You should not put all of your weight on a treatment provider. That doesn't mean they're going to say the wrong thing to you, but know something. It really makes a difference.
Why is it that some patients could use oxycodone over a protracted period of time? For example, one of our members noted that she started using as much as 40 milligrams up to 4 times a day over a period of 10 to 15 years, yet she was able to stop after a successful surgery and with no addiction whatsoever. Why do some people get addicted and other people are able to get by unscathed?
We know that the risks, if you look at addiction having risks and protective factors, my thinking, number one, she has a good number of protective factors, because I could easily make the case somebody on 40 oxycodone 4 times a day for a long period of time would be very dependent on them. Not necessarily addicted to them, but minimally very dependent on them, and would have a more difficult time than you point out this person had. They had the surgery, pain went away. I'm assuming the surgery did that, and then they just stopped. That's a kind of a rare story. They probably would have had to been tapered off, you know what I mean, in some way. And maybe that person was towards the end, I don't know. But I'm happy for them, very happy for them. And whatever their genealogical line is, that's not a bad family to marry into.
One of our members asked a question that was probably motivated by your discussion of marijuana and cannabis, and that is cannabis any more addictive than alcohol?
Alcohol has its own twists and turns, as we all know, and absolutely alcohol withdrawal, not treated properly, you can die. Not the case with cannabis. I think the comparison doesn't work so well, except for they both, in their own way, hurt the brain if you do too much. Alcohol severely so, as you know, it's one of the biggest creators of dementia or contributors to dementia. Well, look, we all love comparing things like that. It's a very valid question, of course, to say the least. But I would say it's a different kind of problem. If you were talking to your children about it, you'd probably talk to them differently. If you were talking to your children about alcohol, you're trying to get them to do the one thing they're likely to do, which is to drive with somebody else or drive themselves intoxicated, and you can get themselves killed or somebody, a friend. Cannabis, of course, as well can. Alcohol's more likely. Cannabis not, you could argue that cannabis used in very moderate ways, rarely, but consistently over time, might have no major problem. But that's not what most people do. That's just not what most people do. People do it, but not most people. And those people, you don't even usually know about them because they have a kind of an ordered life anyway to be able to make that happen.
Okay. What has been the impact of the coronavirus pandemic on opioid use?
Okay. It's had a big impact on opioid use. It's had a bigger impact on alcohol use, I'd say. I mean, I don't have that data in front of me, but a lot of people are drinking heavier than they were before the COVID. There's a reason the LA Times has, it's Sunday, has a cover on it that has been alcohol products every week since the last couple of months. I mean, there's a reason, right? I mean, it's a way we do cope in some ways with the stress, and COVID-19 has plenty of that. As far as the opioids, it's one thing that was a real problem was getting, like the buprenorphine I've been describing, them getting their buprenorphine in a regular way. That's not so easy. Pharmacists, frankly, not all certainly, but some percentage have a sense of their own stigma about people who take opioids, including buprenorphine. So they're not real happy about facilitating you getting them, which is our sad state of affairs. I'm not saying tons of this is happening, but it's being written up, it's happening. Treatment has been interrupted dramatically. So the people in treatment, it's been a lot more challenging. However, there's been some very creative medical centers and other kinds of healthcare systems that have been able to figure out a way to keep the buprenorphine getting to the people. And that's good. And as far as others, probably the biggest thing is people are not going to be getting the treatment they need for the opioids. If they turn to opioids, is there an increased likelihood of opioid use to cope with COVID? You bet there is. Because for the same reason the people that, you know, got too many pills given after a minor surgery and then they kept treating their emotional states, there's a risk. So yes, but I think the biggest thing as far as real risk is people that were on buprenorphine, could they still keep getting it? Because it's not a cure, I mentioned that, but it will keep you alive. You will not tend to overdose.
Why were the problems with OxyContin not recognized sooner?
I think all countries, our country certainly has a great way of doing the pendulum swing where, wow, everything is about this. And then all of a sudden you're not thinking about that anymore. I think there's a lot of that. And there were probably a lot of happy patients at that early stage, loving the fact that they were being given more opioid pills than they'd ever seen and so forth. And doctors happy that because they were getting more patients than they would have normally gotten because it was such a free market kind of thing, even if they were having to pay for the prescription, which they were by and large. Vigilance comes from education. That's how I'll say it. Vigilance comes from education. You don't have education, you don't have vigilance, and you'll put up with a lot of things. Look at American freedom. Just leave it at that. You know, we need vigilance, but therefore means we have to really understand why we live in a country we love. You know what I mean? What are the special aspects of the US or not? You know, learn a lot. Just learn as much as you can about everything.
Okay, let me ask you one final question, Dr. Wilkins, and that is, has the war on drugs worked?
All the wars on drugs have failed, I can say pretty much uniformly. And including the very big one when President Nixon and others, because what works now with buprenorphine, it's not magic, it's not a cure, as I said, but you can immediately stop the risk of death in someone, not always, but most of the time, if they're on the buprenorphine. Because the buprenorphine, if they're taking it, sometimes the people won't take it because they want the highest of the high and they die then. You see what I'm saying? But
Yes.
if they're taking it, because it's a mixed agonist-antagonist, it's actually protecting you from whatever else you're using and keeping itself in line. It's a very interesting, these mixed antagonists are very interesting compounds.
Well, thank you very, very much, Dr. Wilkins. We really appreciate your taking the time to be with us today. And I will remind our members that our next colloquium is going to be on October 15th. Our guest is going to be former Los Angeles County Supervisor, and now University Professor Zev Yaroslavsky, who will be talking about the future of Los Angeles. And then on November 19th, shortly after the election, when we may or may not know who won, but in any event, Dan Schnur, who we've had as one of our speakers before, who's a political science professor at both USC and UC Berkeley, will be analyzing the election and what thoughts he has with respect to where we are and where we're going.
Wow.
So thank you all very much. Look forward to seeing you on October 15th.
Thank you. Thank you.